Hello students, welcome. Myself Dr. Roshini, your OBGYN faculty at DigiNerve. So we are doing our INI-CET quick revision for the upcoming exam. So next common topic that they commonly ask is your abnormal labors. In that your breech delivery being the commonly asked, let us discuss about breech. Mostly the maneuvers and the figures are commonly given, but let us discuss in brief about the breech. Okay, so to begin with, breech presentation is common at 28 weeks, okay, which is almost 20 to 30% at 28 weeks, but by term it usually becomes only 3 to 4%. Okay, so it is common in preterms and early preterms. Breech presentation is very common, whereas once it nearing to term, it will rotate and come back to cephalic, so it becomes 3 to 4%. Okay, from 30% it will almost come to 3 to 4%. Positions are just like left occipital anterior in the head. Here it comes sacrum. Sacrum is your denominator. Okay, the bony prominence. So sacrum is your denominator. So left sacroanterior, right sacroanterior, left sacroposterior, right sacroposterior. Of all this, right sacroanterior is the commonest one. Okay, this is the commonest presentation. Right sacroanterior. Whereas in head, what is the commonest presentation? It is your left sacro and it is your left occipito-anterior. In head, it is left occipito-anterior, whereas in buttocks, it is right sacro-anterior are the commonest presentations. So, what is the lie in breech presentation? It is longitudinal lie only. So, since the spine of the fetus is parallel to that of the spine of the maternal spine, it is a longitudinal lie. Whenever the spine of the fetus is perpendicular to that or oblique to the maternal spine, then it becomes either oblique lie or transverse lie. Since here it is the same lie, just like in your cephalic, it is same here, but just the head is up, that's all. So it becomes a longitudinal lie only. Whereas denominator, as we already discussed, it is your sacrum. Sacrum is your most prominent bony prominence, so that becomes your denominator. So denominator in relation to that of the different quadrants of pelvis, that is your position. In that, right sacro-anterior will be your commonest presentation. Okay, next coming to the types of breech. Okay, this also they have commonly asked, that's why I'm telling you. Either they may give you a description or they may give you a figure. Okay, whenever everything is well flexed, flexion at hip joint, flexion at knee joint, then it is a complete breech. Normally baby is in a universal flexion position, isn't it? So that makes it a normal position, or that makes it a flexion at everything. That is your complete breech. Remember, for breech delivery per se, complete breech is not a favorable condition. Better than that would be your frank breech or incomplete breech with extended or frank, okay, extended limbs. Your flexion at hip joint but extension at knee joint. So this is the commonest presentation, and most favorable for your vaginal breech delivery is your frank breech, okay, extended limbs. Whereas knee presentation is flexion at the knee joint, whereas extension at your hip joint. You can keep it for yourself and see. Okay, whereas footling is extension at both of them. That makes it a footling presentation. So I'll show you in figures. So this becomes our complete. So here hip also is flexed, knee also is flexed, so this becomes our complete breech. Here you can see the hip is flexed, whereas the knees are extended, so this makes it incomplete breech. Whereas when both the knees are extended, that makes it your frank breech. This is the most common and most favorable position for vaginal breech delivery. Just like here you can see footling presentation, it is extended at the hip also and knee also. Hip joint is also extended, knee joint also is extended. So this makes your footling presentation. Imagine if the knee was flexed. If the knee was flexed, the knee will come down. That makes it knee presentation. Okay, these are the different presentation, and they may ask you what is it. So here you can see the pictures, or you can see the description and tell it. Coming to the diagnosis of breech, it is mostly by abdominal examination itself. So in the fundus, you can see the three significant points for your breech diagnosis is, in fundus you can feel the baby's head. Okay, fundus is occupied by head, whereas pelvis you can feel for the buttocks, and one more is, yes, the FHS. FHS is heard at the midpoint around the umbilicus. You can feel the FHS. So around the umbilicus, mostly on the upper part of the umbilicus, but around the umbilicus, whenever you can feel the FHS, that means it is a case of a breech. Okay, the head is in the fundus, buttocks are in the pelvis, and FHS is around the umbilicus. Then you should suspect a case of a breech, and a confirmation can be done by scans, and scan is routinely available. MRI is not usually done. Coming to pelvic examination, sometimes it gets confused between a face presentation and a breech presentation. Remember a small tiny face of baby, this cheeks only will feel like a buttocks. Okay, so this two of the cheeks will feel like the buttocks or ischial tuberosity, whereas the mouth will feel like that of a anal opening. Okay, so how will you differentiate from that of a face presentation to breech presentation? Yes, this two will feel as your ischial tuberosities and the mouth will feel as anal opening. So you should differentiate. See the cheeks, the prominence, the malaprominence, and this is not in the same line. It is in a triangular position, isn't it? Just like you can see, it is in a triangular position. Whereas here the ischial tuberosities and the anus is in a same line. Whereas in face it is triangular. It doesn't say fall in the same line. That is how you will differentiate on PV examination whether it is a buttocks or a breech presentation. Sorry, buttock present breech presentation or a face presentation. Okay, so this may they may ask you an exam, that's why I'm telling you. Next, coming to the vaginal delivery, this scoring is for whether you can allow patient for vaginal delivery or no. The Zatigini Andrew score or the ZA score, since it's an INI-CET exam, I'm expecting them to ask, but you at least should know the parameters of this. Okay, that is your parity, gestational age in weeks, whereas estimated fetal weight, previous vaginal delivery, cervical dilatation, and station. Of these things, if there is high parity, then high chance of scoring. Okay, the more is the score. Whereas gestational age, term gestation, and your less than term. Preterms with breech delivery as less than 36 weeks, and then comes your estimated fetal weight. That is, if your fetal weight is too high or too low, it becomes difficult. And then your previous vaginal delivery, then more chance of success. Cervical dilatation is good at first examination, and station of the buttocks are down, then it is more favorable. So whom should you allow for vaginal delivery? When there is a flexed head. So flexed head or non-flexed head. So what does it make a difference? If the head is not flexed, what is it called as? Stargazing appearance. This also they have asked many times. So stargazing appearances, hyperextension at the neck joint. You can, if you pull or push in case of breech, there is very high chance of having stargazing or hyperextension at the neck joint. So that is why you should never do pull and push in breech delivery. So whenever there is hyperextension, the head diameter, the mento-vertical diameter will come, the sternum. So mento-vertical becomes a very huge diameter for it to cross through. Next, coming your spontaneous onset, no medical comorbidities, patient is willing with consent for vaginal breech delivery, and skilled team with a complete anesthesia and emergency cesarean availability. Then for facility for to continuous monitoring, then you should allow her for vaginal delivery. Coming to management of breech, the principle is no push, no pull. Okay, never push or no pull in case of breech delivery. Okay, no pushing and no pulling in case of a breech. And breech to head delivery will almost take 5 minutes. Umbilicus to head delivery will almost take 3 minutes. Not to panic. No lifting of trunk more than 45 degrees. If you lift, what will happen? Again, there will be extension at the neck joint. Okay. Baby's back should always face the roof. That means dorso anterior. These are all the points for breech delivery. Like that they will give. That's why I'm telling you, all these points are very important. They are the principles of breech delivery. So baby's back should always face the roof of the room. So that means it is dorso anterior. Okay, face, what is it? Baby's head should face the roof means it is dorso anterior position. That means the buttock should be anterior, the back should be anterior. So dorso anterior position. Passage of stage of 90 to 120 minutes, and active stage of labor almost in your 60 minutes. Covering the baby's part with when it is born. So whenever the breech is born, you should take a breech towel and cover to prevent hypothermia. It will take almost 3 minutes to deliver the baby's head, isn't it? Neonatologist should be available and anesthetist should be informed. Coming to the maneuvers, which is most important, for which we are doing the classes today, is about this, isn't it? So coming to this maneuver, whenever the breech limbs are difficult to pull out, or ideally it should come out on itself till the nape of the neck, you should not do anything. But if the limbs are not able to come out, then you can do your Pinard's maneuver. Pinard's maneuver, P for popliteal fossa and P for your Pinard's maneuver. So you can remember the name like this, it will be easy for you to recall in your exam. So to remove the breech limbs, the P for Pinard's and P for popliteal fossa, that is what you will do. So you will put your hand along the popliteal fossa vaginally and you will press on your popliteal fossa. You can do it for yourself also and see, whenever you press on the popliteal fossa, there is flexion at the knee joint. So with this flexion, the foot will come down. So once the foot comes down, you hold it with your finger, the other finger you grasp the foot and you pull it down. So this will help in the extraction of the fetal limbs, okay, the lower limbs. Coming to the fetal shoulders, how will you deliver the fetal shoulders or the upper arms? So here, if there it is stuck, ideally as I told you, till the nape of the neck it should deliver spontaneously, nothing much has to be done. Whenever there is difficulty, then only you will intervene. If the anterior shoulder gets stuck behind the pubic symphysis, you're not able to get it out, that here you should not do pulling technique, isn't it? So you should not pull. So what you should do, you should either do a Lovset's maneuver, where you will rotate the baby by 180 degrees. As we can see, the sacral fossa is up and pubic symphysis is down, angulated, isn't it? So we know the posterior fossa is already come down. So when we rotate it, it will come below the pubic symphysis and it will deliver easily. So it will rotate anteriorly and then the anterior shoulder can come out. Whereas now the anterior shoulder is stuck. That's why it's not coming. So we should rotate it, make the posterior shoulder anteriorly and then pull it out. So the basic principle here remains as the sacral promontory is much higher compared to the pubic symphysis, and posterior shoulder would have crossed the below pubic symphysis. So when we rotate it, it will come down below pubic symphysis, okay, and then you will deliver the head. So delivery of the head is amongst all the complicated one. So here you will require multiple maneuvers, as we have three most important maneuvers, that is your Burns-Marshall, Mauriceau, Smellie, Veit, and your Piper's forceps. So Burns-Marshall is like this. First, allow the baby to hang on its weight for some time. So it will help in maintaining flexion until you see the nape of the neck, may help in maintaining the flexion of the fetal head. Now, once you can see the nape of the neck, you will do a hyperabduction on the patient's body, just like how it is shown here. Hyperabduction you will do on the patient's body and then the head will slip out. Okay, this is your Burns-Marshall technique. Either they can describe you or give you a photo. Then your Mauriceau Smellie method. Here, as you can see, the two hands, one hand in the PV examination, where the body of the baby will lie on your hand and your fingers will be on the mala prominence, and then it will depress it, help in maintaining the flexion, and then you will extract it. Previously, it was two fingers on the mala prominence, one in the mouth of the baby to help in flexion. But now they don't keep in the mouth, they keep over the chin, or they don't keep at all. So making it a modification, because keeping in the mouth was causing gasping in the fetus. And lastly, your Piper's forceps. These are a long blade forceps. Okay, the blade of these forceps are very long and helps in the body of the fetus to lie over that. Okay, firstly you should cover with the towel and pull the baby like a Burns-Marshall, and then you should put your forceps and extract it. So this is your Piper's forceps. So these are the important techniques. You should know the name also and the figures also of how it is being done. So previously they used to do Prague's maneuver. What is Prague's maneuver for? Whenever, as we told, as the basic principle, the head should be, or the dorsum should be anterior, or back should be facing the roof. Whenever dorso-posterior it is there, dorso-posterior fetus or the baby is in dorso-posterior position, you are not able to rotate, then you will do Prague's maneuver. But now it is not done. Now you will do for elective cesarean in such cases. Okay, so this ends your delivery of the breech. Now let us do some quick revision of MCQs for that. By doing external cephalic version, since I have not discussed external cephalic version, I am just just given a question of that. ECV is your external cephalic version, better done after 36 weeks period of gestation, when the uterus is not in labor. That means a relaxed uterus, liquor should be adequate, more chance of having vaginal delivery, almost 65%. Okay, success of ECV is asked, it is approximately 65%. Whenever you do a ECV, you should make sure that there is enough uterine relaxation, enough liquor for the baby to rotate, and you should rotate in such a way that the baby is maintaining its flexion, and every 15 degree or every 90-degree rotation or 15 minutes you should make sure you adhere to the fetal heart rate, and you should make sure there is no placental abruption post ECV. Okay, so you should know the timing of ECV and indications of ECV. Whenever there is a chance for vaginal delivery, then only you should do a ECV. You should not do it in a complicated cases like big baby, oligohydramnios, IUGR, anomalous fetus, or in case of previous LSCS, GDM, hypertension. In such cases you should not do. Only in a non-complicated case you should do ECV. So by doing ECV, that is your external cephalic version, what will do, will push the buttocks up and bring the head down. So what will happen, will the lie of the baby change? Previously it was longitudinal lie. Now also it is a longitudinal lie. Just we have replaced buttocks and its head position. That's all. So this is wrong. Attitude of the baby. Attitude means relationship of one to itself. So head will be flexed before also, now also. So this also is not going to change. Rotation of the baby from posterior to anterior. Are we rotating anterior to posterior? No, we are rotating from fundus to pelvis, not from anterior to posterior. So this is also wrong. Presentation is changed. Yes. Presentation means your initially presentation was buttocks. Now the presentation will be cephalic. So this will be your correct answer. Next question. The bitrochanteric diameter of the fetus in case of a breech will be what? It will be, bitrochanteric diameter will be your 10 centimeters. Between your two trochanteric diameter is 10 centimeters. Head of the baby is delivered by following methods. Forceps, that is your pipers, yes. Burns Marshall, yes. Burns Marshall is correct. Mauriceau Smellie method is also correct. Lastly, Lovset's manual. Lovset's manual is for delivering the shoulders, isn't it? Not the head. So this is the wrong answer. So this will be your answer. So here ends your breech presentation. I hope this helps you. Other abnormal labor also may be asked, but commonly is breech. That's why I've discussed this. All the best for your INI-CET exams. Thank you.